one thing that I wanted to allude to before we end, and this has been a fantastic conversation as always. I learned so much just being in your presence and having the opportunity to discuss with you. I did want to allude to some of the newer trials. We've been focusing mostly on the RCTs, sham-controlled trials, but let's talk a little bit about some of the recent trials in the vertebral augmentation world, kind of how that is changing thought towards acute versus chronic and the timing versus pain factor. Well, what's new in that realm?
Yeah, that's a great question. And I don't know if you're doing it intentionally or not, but, playing up to my ego because I was part of one of those, I think, important trials. So Vertos is a very prominent study group. They did Vertos 2, which everybody in our community loved, Vertos 4, which everybody didn't love, although I believe in many ways Vertos 4 has set the stage for understanding things better. As I've alluded to before, Vertos 5 was a study of chronic compression fractures. I've hated the term acute, subacute, and chronic because I think they're actually incorrect in this, but that was how Vertos 5 started, so that's the terminology that's used. The reason I hate it is because why would we think, so Jacob, God forbid you fell off of a ladder. I would never be on a ladder, so I wouldn't fall off a ladder. But, you look like a young, healthy, vibrant guy. If you fell off a ladder and had a compression fracture, at least in 2025, I wouldn't offer you augmentation. I would say, Jacob, you're likely to get better pretty soon. Why? Because Jacob Fleming is going to heal. You're a young, healthy guy. Who are we treating? In Europe, in some places, they're treating traumatic patients, but for the most part, we don't in the United States. We're treating osteoporotic patients and we're treating patients who have cancer. They do not heal the same way. So for me, acute, subacute, chronic, which again, working with Dr. Greg Hogue, who was an excellent carrier medical director up at NGS and led the first multi-jurisdictional MedCAC, we talked about this a lot. He felt because the literature talks about acute, subacute, chronic, that's what we have to stick with. My issue is acute in you and me implies a certain healing rate that is completely different in the vulnerable populations we described above. So yes, Vertos 5 specifically looked at chronic fractures, but chronic fractures that I would believe should be treated now because chronic implies healed in people's mind. These fractures were shown to be unhealed. They had the similar radiographic findings that the patients had, let's say, at 2 months. So for me, it's really a question of healed or unhealed. And if it has healed, if it's healed, for example, with a pseudoarthrosis, something that's unstable or a big area of avascular necrosis, of course I expect that patient's going to get better. Now, I do think that some of the more exciting work that's come out recently is not trial specific, but also things that look at adjacent level fractures. And very, very pleased with the meta-analysis that came out in the European Journal of Radiology that said ALFs are not more common. By the way, this was something that when you looked at the individual trials was clear. So aggregating them together in a paper specifically focused on that using a technique called a network meta-analysis where you can compare 3 different variables. Natural history did appear the same. Now, if you ask me from personal experience, if I were to be in a perfect world, I would actually say that the Europeans have it right. Treating vertebrae that are, let's say, in the thoracolumbar junction that are adjacent to a terribly fractured vertebrae that you're rebuilding would potentially be of benefit because I do think it's lost in the giant data sets. There may be higher instances of adjacent level fracture in particular types of fractures. We're not there yet. We have to do subset analysis, but I do think over time we all learn from each other. And I think that some of our European colleagues and South American colleagues, basically colleagues from everywhere but the United States, I think, have said there are times you should do more than treat the incident level. You should consider the levels adjacent. And what I would say is if natural history data suggests that the treatment arms are the same as conservative therapy or natural history, that there are subsegments of patients that might benefit from additional treatment. And then if you can improve what your historical rate was, let's say with kyphoplasty, then you're better than natural history. And think about that. So you didn't ask me this, but I'll take the opportunity at a conference abroad. a consensus began to emerge about a topic that I find near and dear, that if augmentation wasn't strictly viewed through the narrow lens of pain improvement, how it sort of developed historically, but rather we looked at height preservation as shown in Virtus 4 and Vapor, height restoration as shown in many, many different papers. If we look at diminished opioids, which have been shown in papers, if we look at all of those different things, maybe it's time we stop thinking exclusively about the pain. Maybe it's time to even stop thinking about pain and disability, because there are benefits that are not considered when you look at things in that lens. And I think the title of that paper played off on Carly Simon's classic song. I think it was something along the lines of, is it time to get past the pain? And I really believe that. I believe had this field not grown organically, but if we could have started it and understood what the world would look like 30 years later as we're thinking about these questions, we would have talked about sagittal correction. We would have talked about objective parameters of assessing people's breathing ability, narcotic dependence, things that are very easily proven in a trial against sham, and not specifically focusing on the subjective assessment of pain that, at least in 2009, really ended up causing a lot of difficulty for these patients. Pain and disability definitely do not tell the whole story.
Absolutely. And I think we've covered so much today. I have a lot to digest